interest. So I probably, instead of my 75 slides, I'll stop at slide number 2. So I would like to I'll start thanking Adrian for a wonderful organization, to Marcus, to OCTA, to Alan who is here. It's really a wonderful setting, and I'm amazed that people are so interested by neuro-ophthalmology. No, this one, please. No. So if you don't mind, yes, if you don't mind, being 230, 220, everybody must be somehow postprandial. That should be good. Postprandial timing. So I would just like to entertain you about different stories I'm a neuro-ophthalmologist and I'm a neuroscientist at SNEC. I would like to thank my co-authors, Ben, who must be in the room, and Marcus, who in fact initiated all this. You'll hear more about this. I have no conflict of interest. Oh, that's great. No conflict of interest, but again, I would like to thank this wonderful setting up to view Mohan, who's here, who helped us a lot. In neuroscience, and when it comes to brain and vision, what's most important is this question. What's more important to image? Is it structure or function? Are we taking care of cells or the way they're functioning? And I've done quite some work in neuroimaging. And I can tell you that we'll hear wonderful things here about functional imaging, about vascularization. But I can tell you, the guys who are doing brain imaging, they are 10 years ahead from us. Way ahead. I'm going to show a couple of examples. For instance, this is a patient. Do we have a... Right, this is... do we have a laser pointer, please? The round button. Oh, the round button. Okay, right. So this is a patient who had epilepsy, and he was discovered with this lesion in the brain, which turned out to be a glioma. That was a surgical lesion, and the surgeon wanted to know, can he take that region out without leaving the patient hemiplegic? 10 years back, we just didn't know, hoping that after surgery we'll wake up able to walk. But functional imaging, which is a different story, this is functional imaging for the brain, is looking at the brain, how it works, brain at work. We're not there with the retinal imaging yet. Hopefully we will, but not yet. So what's functional MRI is making the guy move his finger in the machine and looking at the blood flow and to look at the consequence of that blood flow, which is a sort of proxy of the neural functioning. And look how cute this is. The guy, while he's moving his hand in the MRI, this is enhancement of those areas. So what's the consequence? This surgeon just can go comfortably and remove this thing. If you leave this thing out, the patient will be on the safe side. He will not be hemiplegic. It's very important. Now, brain imaging has evolved really a lot. This is 15 years back. And neuroscientists have explored all sorts of things. Language, vision, emotions, and even crazy stuff. I mean, look at this. Samir Zeki had looked at the neuronal regions involved in perception of beauty, and believe it or not, they did MRI, people looking at ugly things versus beautiful things. They're looking at beautiful things, different areas in the frontal areas are activated. How far are we, exploring function from all those things? Very far. So, what to do about, why are we interested in functional imaging of the retina? Me as an ophthalmologist, I'm of course interested about function more than image. Let me show you a case. This is a patient who walked in with a little bit of headache, normal visual acuity, visual fields, a little bit of enlargement of the blind spot. What do you think the ophthalmologist did? He scanned the patient. That's what you probably would have done, right? The scan came back normal. What would you do? I'm going to tell you what the ophthalmologist did. He said, come back in 2 months to see what happens. The patient, very disciplined, came back 2 months, again, normal MRI. The guy came back 2 months later with this picture, and that's not good. And we knew already, for looking at the vessels, because this is the theme of the day, there is maybe a little retinochoroidal shunt over here. And if you were able, this is a good sign for me that there is high pressure behind the eye, there's no doubt about it. But if you could have a method to measure that, to quantify it, and to follow up, an angio-OCT, I thought would be a good thing. It would be wonderful. This is the bad story. Let me show you the good story. Another patient now with a similar picture, papilledema on this side, already atrophy on this side, but again, remember that's retinochoroidal shunt, meaning there is high pressure. What did this patient undergo? Neurosurgery, ventricular derivation right away. I look at the result 1 week later, the shunt disappeared within 1 week. Wonderful. And the papilledema disappeared, recovered vision. How wonderful is that? So I'm very interested in neuro-ophthalmology to look how the vessels look, because for instance, if I'm seeing one of those patients, let's say, let me ask you this. Let's say you will treat one of those patients who have, there are 2 patients in your waiting room. They are both blind in one eye. This is how their fundus looks. One of them will get steroids. Which one? You have no idea. I don't. Right. But you better look which one would get steroids. Because in one case it was syphilis, and this patient shouldn't get steroids because you will know the next day you did the wrong thing. Right? So again, is there a method? Because in ischemic optic neuropathy, what we thought is that what if there is something wrong with the vasculature that we can pick up with angio, OCT, that would be good fun. But this is why when Marcus told me, was it 6 months, 8 months ago, let's do something about this. I said, wow, that must be very cool. And let's start with some references. Let's see what the literature says about this. And that was the bad surprise. No items found. There is nothing about angio-OCT in neuro-ophthalmology. You will probably hear today about the biggest series in papilledema in the world, which is my case. So when we're talking about optic nerve and optic disc, the appearance could be even swollen disc, of course, normal if the pathology is way behind the lamina fibrosa or atrophic as we saw. And those are the common situations of swollen discs. If it's unilateral, it's an optic neuropathy, and your workup should be able to determine if it's compression, if it's ischemic or inflammatory. Of course, the treatment, the follow-up, everything is different as opposed to intracranial hypertension. This was the first patient that I saw with idiopathic intracranial hypertension. It would be, we ophthalmologists had a very prominent role in diagnosing those things when we were used to do angiography, right? Doing angiography in ischemic optic neuropathy, that was a very good tool, because if there is choroidal infarction, that tells you there is something wrong with the posterior, with the PCAs, right? So, let me start the talk now by saying that we used the AngioView, OCTA, the OCTA view. We looked at the optic discs, and I'm very happy that Michel did already an introduction of what's normal and what's normal in glaucoma. And we looked at RTC images in a couple of situations. Let me show you a couple of cases. So look at this patient. I mean, it's not that difficult to think that this is probably ischemic because of the hemorrhage, because of the segmental optic disc edema. But sometimes it's not easy. What does OCT show us? Oh, the classical OCT just doesn't show us anything. It's just edema all over the place. But look how funny this is. When we look at OCTA in ischemic optic neuropathy, you just see, I would call those, I don't know, engorgement or tortuosity of the capillaries, as opposed to inflammatory. It doesn't look that bad. Again, as I told you, there is nothing in the literature about that, so I browsed the existing literature, and the only thing that I could see, that I could find, do you agree that in a vein occlusion, this image is a bit, those congestions of the capillaries are somehow similar to what we're seeing in this ischemic optic neuropathy? Could be. Let me tell you this. The do not repeat that I told you this. Neuro-ophthalmologists have no idea what ischemic optic neuropathy is. Right? There is nothing really known. There are a couple of pathology cases. So there is the giant cell arteritis, which is the arteritic ischemic optic neuropathy, and we know quite a lot about that. That is just a massive thrombosis of the PCAs in giant cell arteritis, which is a very rare condition, by the way, of course, in Asia and Singapore. But in non-arteritic ischemic optic neuropathy, NAION, we don't know. Is it vasospasm? Some people even want to call it as a venous problem, vein problem. And this is very interesting because this looks like what this could be. We have no idea. Is it vasospasm? What's the role of a small disc? What's the role of nocturnal hypotension, of sleep apnea, etc.? Briefly, I have no idea what's going on. I'm not the only one. So it would be very nice to do to explore those patients with OCTA. That's what we did. I'm not going to bother you with vasculature of the optic nerve, although it's a fascinating subject. And if you know the name of Hyre, and you probably heard him speaking or screaming at his opponents, right? And absolutely very passionate debates about vasculature and the pathogenesis of ischemic optic neuropathy. But just to remind you that the same vessels, the PCAs, which could be short or long, it's a very complex story, come into the choroid, also irrigating the anterior part of the optic nerve just in front of the lamina cribrosa. What's the consequence for us ophthalmologists? Is that somebody who has an ischemic optic neuropathy in this area, because if it's behind the lamina cribrosa, you will not have optic ischemia, that will be a PIL, a posterior optic ischemic optic neuropathy. So they should also have at the same time not only optic ischemia, but also some problems in the capillaries. So this is why we're very interested about OCTA, and there were some brilliant studies in the past. The watershed zones, remember, the lateral and the medial PCAs, and there's a sort of no man's land in between those two territories. And if there's lack, this is a giant cell arteritis with a very pale disc. So in this case, we expect to have deep abnormality. So the aim of our little study was to look at NAION. Is there something specific in NAION as opposed to other optic dyskinemas in other conditions? Patient number 1. Please have a look. This patient had the ischemic optic neuropathy in his right eye, and you probably see a segmental dyskedema here. Do you agree with this? And look how interesting. There is something wrong here. And in the grid also, I don't know if everybody can see, right? So there is hypoperfusion in this area, as opposed to this optic nerve, which looks just beautiful. So this is interesting. So this is a total thickness image. And unfortunately, we do not have data for the deep layers, which is probably the next step we should do. And Michel told you about the flow density. And look how interesting that this index, which, by the way, I still think is an arbitrary number. It's not something, I don't know, the specialists, what do you think about that? How much should we rely on those numbers? Probably not. I see the design, no. So, but nevertheless, in the inferior temporal side, 50 as opposed to 60, I think that sounds, I have no data analysis, I don't have no statistical analysis. But that fits what my gut feeling, there is something wrong here. And again, those images, we cannot see them with conventional FFA. Patient number 2, a similar story, and you probably agree that there is something wrong here, that is visible also here on this grid display. And again, this is also verified on the angioflow density charts. And this is a phenomenal situation. It is just a follow-up of a patient who has an exceptional situation, but which actually is the reflection of a natural phenomenon, which means that AION, we call it sometimes a stroke, right? A stroke of the optic nerve. I don't think it's a stroke, because we cannot have a little bit of a stroke, or it's either you have it or don't have it. Well, in AION, there's this entity which is called the incipient AION. A significant number of patients with AION, they already have an optic dyskedema that is incidentally found, and then they end up having the disease. I'm not sure if I'm clear. Well, let me show you the case of this patient who came in with an acute loss in this left eye, 645 vision. And interestingly enough, he also had this aspect of the right eye, of his right eye, vision 6.6. Let me ask you this. What would be the first thing that you would do? OCTA? No. What would that be? CT scan, thank you. You don't have to sleep, that's good. So, what you all want to rule out is an intracranial process, right? But in fact, this poor patient had a left NAION, and he has this incipient NAION in his right eye. And look what OCTA A gave us. Fascinating stuff. Remember those congestions of the venule? I'm not sure. I have no idea if this is venules or not. Pathology, in one case I showed us, this could be venules. So, congestive capillaries in the left eye and the right eye, despite the optic disc edema, I mean the vessel network, micronetwork looks good, right? Unfortunately, we knew exactly what was going to happen, which was visual loss in his second eye. So FFA did not bring us much, and then he had 1 month later, of course, he had visual loss in this eye, the worsening of the optic disc edema. And look at this. Now, I think you see more tortuosity of the capillaries in this side, and he got better in this eye, which is verified by the grid images. This is the left eye, blue patches all over the place here initially, and after 1 month, I think there's a decrease, which is verified by the aspect of the optic disc. And just to make it short, I do not believe that the flow density charts are of any value, and probably because the optic disc edema is also inducing a lot of artifacts. I think the segmentation is horribly different in those cases. So, conclusion number one, I think that OCTA AION may disclose non-perfusion areas, all those blue patches areas, and that's consistent a little bit with the pathology of the disease. Abnormal capillaries and vascular congestion. However, I have no idea if there's more involvement of the superficial or the deeper layer, which would be of paramount importance for us to understand the disease. And how much time do I still have? Am I running out of time? All right. So and then wanted to see how about other causes of optic disc edema. We see them all the time as ophthalmologists, right? So in this case, this was intraocular hypertension. You see bad papillary edema, but look at that. The vascular pattern just looks good. It's a different story. This papillary edema may not look different from a papillary edema in ischemic optic neuropathy, but the pathogenesis may be different because the vascular pattern is different. Same thing here. Beautiful network. Look at this network here, which is, to me, looks within normal limits. And look at this case, a patient with meningioma and optic disc edema. And again, this looks just good. There's probably a little bit of dropout here, but not much, not significant. And the other thing that I was very interested in is to look at optic disc atrophy. And as you know, in labors, there are those peripapular telangiectasia. I didn't get the chance to see those, but it would be a fascinating story to have. But in optic disc atrophy, you see massive drop-off of the capillaries and the blue patches everywhere, which is consistent with the capillaries lost. One of the issues here is, which I don't know, is what's causing what? Is it neuronal damage causing consequent less metabolic needs and death of vessels or collapse of the vessels? Or is it the other way around? I don't think anybody can answer that question. But it is a very interesting question because there will be treatments for it. There is a couple of treatments, gene therapy for labors. So this would be a phenomenal tool to look, to follow up on potential recovery. Are mitochondria working better in this disease? Is the blood supply improved, etc.? And last case, I just want to show you this exceptional case of a patient with optic disc hypoplasia and an AION and optic disc edema, and look at those images. Fascinating. There's nothing left. Basically, only the big vessels or the capillaries are just gone. So, in conclusion, we're still at very early stages of OCTA, especially in neuro-ophthalmology. I've never heard or seen I don't know, the experts, but did you hear about neuro-ophthalmology and OCTA? Yeah, so it's really, I have no idea what I'm talking about. Is there a gap to be filled? Certainly. I think there are major questions for us physicians in terms of treatment, prognosis, etc. And well, a couple of limitations that we've been talking about, and the role of capillary involvement. Thank you very much. Thanks again for inviting me. I don't expect any questions.
Of course there will be questions. Have you had an opportunity to do OCTA on optic neuritis?
Oh, yeah, so that was one of the cases that I've shown you, yes. So there are some abnormalities, but not vascular dropout. No, I could not quantify that. I showed one case, but I think it's a very different story.
There's no way to differentiate an optic neuritis from an ischemic. So on optic neuritis, there is no dropout.
Not as I've only seen one. I looked only one case. So Adrian, if you invite me again next year, yeah, I'll bring you more data about it.
I'll remember that. Now, why do you think that you don't get congestion of the deeper plexus with papilledema and intracranial hypertension, that back pressure? Why are there no changes on the OCTA?
I hope no one would ask that question. I don't know. I have no idea. I have no idea. Maybe one of the thoughts is, what if this papilledema, stasis papilledema, what if it's a chronic process and it's sort of compensation? I have no idea. I don't know.
It would be interesting also
to
look at the collateral vessels, the shunt vessels.
Absolutely, absolutely.
So for those of you who have an opportunity, when you see shunt vessels and so on around the nerve, to try and get an image on the OCTA and then send them to them.
Okay, absolutely. Image them first, right, to rule out a big tumor in the brain.
Thank you for your talk. I don't have a question for Dr. Milea, but we did a lot of OCTA on NAION patient. During the edema stage, I think the OCTA is not that reliable because of those, edema caused the artifact of the scan. But after 1 month, when you do the follow-up, you can see the capillary changes and corresponding nerve fiber layer changes. I think in our experience, we also do the OCT disc scan with GCC, and it matches the GCC loss very well. The second case that showed us a labor case, we also have a lot of this kind of case in my clinic. And I think the macular papillary bundle defect is very significant in this group. And our OCTA just showed very well, the relationship between the nerve fiber loss in the macular papillary bundle and the capillary loss in that area. That showed very well. I think that this is very useful technique for checking this LHO in patient.
Could be. True.
Have you imaged any traumatic optic neuropathies?
No. Very good thought.
We're always thinking whether steroids are useful in some cases.
Yes, very good thought. Very good thought. And we all know we're very reluctant to give steroids, right? But then if you had a vascular clear component, one of the things is that how do you know? I didn't have time to talk about this, but what in all those conditions? What if it's not an arterial problem? What if it's a venous problem? For a venous problem, we still have a couple of options, right? And it's not only, when we talk about trauma, it's steroids or not, but there might be some other options. So I think it's a brilliant idea, absolutely.
Okay. No other questions? Thanks very much, Dan. You've stimulated a lot of thought and discussion, so we've got a lot of homework to do. Since we just had lunch, so we're going to move on to the next lecture. I don't think you are up to tea just yet, right? So we're going to ask Michelle Puch to now talk about angle imaging and the plateau iris. Thank you, Michelle.